Well, I'm Dr. Simon Thomson, and I've been a consultant in pain medicine and anaesthesia at Basildon and Thurrock University Hospitals since 1992. So I'm just celebrating 20 years. In 1993, I did my first spinal cord stimulator implant at this hospital, having learnt how to do this back in 1989 in Sydney, Australia. Since then, the service has grown, and Basildon's reputation for providing spinal cord stimulation has spread ever wider. And having started with about 3 patients per year, we're now seeing and treating about 60 to 90 patients per year. So there's been a huge increase over that time. Chronic pain is the silent epidemic that affects all populations throughout the world. It's been very poorly recognised by the health economy, and generally the healthcare systems prefer to use pain as a symptom in order to guide treatment of a specific underlying disease, with the hope that that pain would then subside. The sad truth is that model of management doesn't actually work, and there are many patients who fall through the gap, really, of lacking an adequate diagnosis, or even if they have a diagnosis, there isn't a specific treatment. So it turns out that about 17% of Europeans will suffer from significant chronic pain, which affects their activities of daily living, and a third of those are really quite severe. And probably about half of those are caused by neuropathic pain. Now, neuropathic pain is pain that is caused by damage to the nervous tissue. Our whole bodies are invested with nervous tissue. Most tissues are innervated by nerves, and there are nerve endings in skin, in muscle, in bone, and in the internal organs. And they are linked through a complex of relay stations through the spinal cord and into the brain. And it turns out if you damage that system in some place, whether it be centrally or peripherally, there is a chance that that person can develop spontaneous pain known as neuropathic pain. And this is also the sort of pain that is effectively like a hypersensitivity. So typically patients will complain of a burning or shooting pain, often in an area of altered sensation. The pain is continuous and is rated as really quite severe. And in fact, studies have shown that patients with neuropathic pain suffer a far depressed health-related quality of life than even other patients with typical types of nociceptive pain, such as rheumatoid arthritis and osteoarthritis. So really these patients with neuropathic pain are really quite sick, and yet the healthcare systems throughout the world have never really produced any specific answers to these patients' needs. Over the last 20 years, there has been an increasing recognition of neuropathic pain, and new agents such as pharmacological agents have been produced which have got fewer and fewer side effects and more efficacy. But despite that, there's still a large number of patients who have what we call refractory neuropathic pain, pain that isn't helped by some of these agents that have been developed. And it's these patients who can be greatly helped by spinal cord stimulation. Over the time that I've been treating patients with spinal cord stimulation, there's been a steady improvement in the technology, with a significant step forward from time to time. When I first started, we only had access to radio frequency coupled devices which could drive only 4 electrodes. So the patient would always have to wear something on the outside of their body that would transmit power to something implanted inside them. Now we have fully implantable systems with rechargeable batteries which are capable of driving 16 contacts and shortly perhaps even 32 contacts of leads that are placed in the epidural space. One of the things that used to blight this technology was some of the non-dangerous but very annoying complications. Sometimes the hardware would corrupt internally and we'd have to replace some of the electrodes. But the most important thing is that the non-rechargeable batteries would go end of life, as you would expect. A variable time that would take depending upon the energy requirements for that individual patient. But it would mean that the patient was shackled to having at some stage their device exchanged. Now we have rechargeable technology, and we are hopeful that these rechargeable batteries will allow cycles and cycles of recharging that might allow the device to last up to 25 years. At the moment we've been using these systems for 8 years and we haven't had to replace a battery yet. So we're pretty pleased about that. And that not only reduces the burden of therapy for patients, but also the burden on us providing a service, as well as those that pay for it. Consequently, because it's a one-off treatment at the beginning, the actual payback grows ever more, such that the annualized costs of a patient being treated with this condition gets less and less with time, and probably breaks even round about the 3 to 4 year mark. So if you can provide relief for patients 10, 20 years later, then you are making a significant health cost saving. So our patients are really pretty prepared by the time they get into the operating theatre for the first day. And on that first day, the person who has spent time educating them is with them in the theatre. And after careful and usual theatre management of cleansing the skin and surgical technique, the patient is lying there, fully awake, no sedation, and local anaesthetic is infiltrated into the skin at about the high lumbar area. And a small cut is made, which is then painless, and then I dissect down to the muscle coverings, and at that point with a small needle find the epidural space, which is a space around the spinal canal, but not in the spinal cord, but outside, outside, and then thread some electrodes into the epidural space under X-ray control. Under the image intensifier, which is a type of X-ray, I'm able to see the passage of the electrodes through that needle into the epidural space and threading them up to the desired level in the vertebral column. When I'm happy with the position, I can then connect it to a temporary screening cable, which I pass to one of my team, who connects this to the computer and then starts to map out where the patient feels the sensation of pleasant tingling in their body. The patient feeds that back to the therapist and me, and then we change the array of pluses and negatives on each of the 16 contacts until we have found the optimal place so that we, if you like, light up the whole area that the patient is complaining of pain. And if we can do that, then we're very pleased with ourselves. And we would then anchor the electrode to the fascia, which is the covering of muscles where I have dissected down to, and anchor the electrode so it won't move. I then connect it to a temporary extension and draw that out under the skin somewhere else so that the patient can go home with a temporary external stimulator. And for that week, they can then test out the stimulation, which exactly mimics the stimulation that they would have with the fully implanted device. And that's the beauty of spinal cord stimulation, because it allows a relatively minor procedure to have big effects, but it is reversible. And if it helps significantly, and these patients are then assessed by another member of my team who is independent to their care, who then assesses them, and if they satisfy the criteria of success and they wish to proceed, then a week later they come back. The external temporary extension cables are removed, the wound reopened, another pocket made, usually in the upper buttock, and the leads connected to that, all under the skin, and the wound's closed. Afterwards, the patient is taught how to use the handheld programmer so that they can then adjust their programs how they want them, how they want it in the sitting position, lying position, walking, the intensity. They can have different programs if they want it more felt, for example, in their back and less in their leg, or more in their leg, and so on. They're also taught how to use the rechargeable, how to recharge the device, and how to care for it generally. And it is quite extraordinary in a way how access to this treatment hasn't increased as rapidly as we might have expected. And it isn't necessarily because of lack of funding. Unfortunately, it is about trying to change hearts and minds of not only patients, but also of their treating doctors, to realise that what advantages can be gained from spinal cord stimulation. And I think this is now going to be the challenge of the future. And it's the initiatives like this, trying to increase awareness, and all the work that the professional societies do, trying to engage with doctors from different disciplines to try and demonstrate the value of spinal cord stimulation. What we hope is that this effort will translate into treatment pathways so that treating doctors will more quickly know when to refer patients to a spinal cord stimulator centre.